Hello, everybody. I don't know if can you hear me? Yes, yes. It's my pleasure to start the first clinical session today, and this will be on VT ablation. We will start with 4 lectures. We have 4 excellent presenters, and this lecture session will be immediately followed by live cases, and we have 3 live cases, 1 pre-recorded case. So I would like to invite Peter Peichler, who will share with his experience with PFA in VT ablation.
Dear Chairman, ladies and gentlemen, I'm very honored to be here. So why to think of the pulse field for VT ablation? Well, there are lots of limitations and potential risk for RF. We know that for many years. If you have a scar-related myocardium, the RF is limited in terms of penetration. If you have thick myocardium, like interventricular septum, if you have tiny spaces like a coronary sinus, venous vasculature, you are limited by impedance, temperature rises. If you have moving targets like the papillary muscles, which are very highly movable structures, the RF, long application of RF is difficult. And in epicardial space, there are risk of collateral damage. And above all, if you really look for large lesions and you go for thermal energy RF, you inevitably enter in the regions you may increase the risk of steam pop because you accumulate a lot of energy into and this is the ice image of the steam pop in the animal model, and you can imagine what happens. On the other hand, pulse field has some benefits over RF. It's probably better penetrates through the scar tissue. These are data from Elad Anter group showing with the RF lesion, the pre-existing scar protects some of the areas that we want to target potentially, and that might not be an issue with the pulse field, which is a field that somehow can cross this and maybe better in penetrating the scar tissue. There are data on that. And in their catheters nowadays made that like the Sphere 9 with a Affera system that can make a larger lesions because of also the larger footprint. So these are data also from the preclinical experiment showing if the SDSF 50 watts, 106 seconds, you end up somewhere in the 6 millimeters with either RF or pulse field. You can enlarge the size of the lesion dramatically, and that's relevant for the ventricle model. And also there are some animal experiments showing if you really look for large lesions, the pulse field in the bipolar configuration, these are the lesions that by 2 sphere on the septum from the other side, showing these very maybe scary images that shows you the potential of the technology. So this is probably for the larger lesion better way. But there are some downsides of the pulse field technology, and I will try to show them what we learned over the last 2 years in terms of the risk of conduction system damage, spasm, myocardial stunning, and higher chances for recurrences. So if you have this as a plan, it never works in the reality. That's the ups and downs of what we found. And we published 2 case series, one with the kind of what was available 2 years ago for us. It was the Centauri generator, which is a generator that can be connected to commercially available catheters. We use Smart Touch and use Cardo system. And we have combined experience from 2 centers, 44 patients with ventricular arrhythmias, showing a quite good outcome in the population of patients with the ectopy, a little bit less with the structural heart disease. And the case that made it for us was this one, which was a non-ischemic cardiomyopathy patient. 3 VT morphologies, very similar, but a little bit different, and they all originate somewhere from the LV summit region. And when we mapped endocardially during these VTs or ectopies going from this region, if the endocardial LV endo was late, what was very early was the CS, distal coronary sinus. So epicardial summit of substrate, and also the pacemap was perfect there. So, and if you work and ablate in the distal CS, that's usually you're limited by the RF, by the impedance, temperature, and we use pulse field, which we did coronary angiography. There was no change, and these applications from endo-epi did work for the guy, and for more than a year he never had recurrences, which led us to expand this. So can we maybe use the pulse field with this focal catheter to some small areas that the RF is limited. This was the series that we published. It didn't work for everybody. Obviously, if you are you have to be close to the substrate. And work for the patients that had a reasonable prematurity in the distal coronary sinus or great cardiac vein. And in this series, there was no kind of spasms noted, probably because most of the coronary arteries are protected by fat. Obviously, if you feel that after 11 patients you understand everything, you haven't done enough. So there's a recent case that we also use it for PVC going from the summit region. We did application, and when we shoot coronary angiography, you can see a spasm between the circumflex and the marginal branch. And this is fully reversible. This is after some time later on. This is completely reversible. But there are no ECG changes unless you shoot coronaries. You are not aware of this, but just it shows you the potential. So even the focal catheter, small tip, you can cause this from ablating from epicardium close to the coronary arteries. As was mentioned also in the Fermin's talk, you can also have a spasm from ablating endo. This is the RVOT. This is, as he mentioned, LAD, very close to the endo RVOT site. So this is a common RVOT ablation. Actually, it was a failed procedure. That's why we use pulse field. And when we ablated over this coronary artery, this was the result. Again, the spasm, which was fully reversible, but something to really have an idea about, and you should be aware. We don't know the long-term effects of this. This is something that we should be paying attention. But I still consider pulse field a lesser evil compared to the RF, because there are data showing if you use RF in some of these regions, you may occlude the arteries. This is a case series of 5 patients. And then they're ablating in the RF endo RVOT, and there were 4 occlusions of LAD. So having a spasm is better than have a complete occlusion. But obviously we need the long-term data on this. But we also saw some unexpected technical problems which we didn't expect that may occur. So this was a case, kind of failed VT ablation, about 6 procedures prior, hypertrophic cardiomyopathy. We did use something which we considered could help, which was the pulse field. But after the pulsing on the lateral wall, you can see this is written before, this is the pulse, and you can see AV block. And while we were very far away from the AV node, we were somewhere here, and the AV node being here. So what's going on? We were very puzzled by this. It turned out to be a technical issue because we were using the Smart Edge, and the Centauri that time somehow had some current leakage from these proximal electrodes, which is normally used for tracking the shaft of the catheter. So generally, if you ablate it, transeptally you will cover this with the sheet. If you go retrograded, this electrode actually ends up somewhere where his region may be. That explained the AV block bit. This was temporary only, but something you'll be aware. Obviously, this is a technical issue that can be, it's probably for this combination of Centauri and Smart Edge, but not for the other technologies. Okay, so then there was the focal catheter experience. And can we go and image the presentation again? Okay, so then we had the chance to try also the other system, which is the FERA, which is a larger footprint catheter, 9mm tip. We also publish our data, a very early kind of experience. So generally, first I would say that the system is very good for mapping. So it's a combination of all-in-one. So we have the same catheter for mapping and ablation using both RF pulse field. So you can map the whole VT circuit if it's a tolerated VT, like in this septal post-MI substrate, and ablation here obviously terminates the VT. You can use both RF and pulse field. This was a patient with ARVC that had ablation in posterolateral RV. We used pulse field for that, and she had a recurrence more proximal or more to the apical part. We could remap after 3 months, and it really was so that it's very effective way of creating scars. This failure of why she came back was because we didn't, I would say, be extensive enough for her ablation, but the remap showed that these lesions are durable. Another example, a patient with correction of tetralogy, correction of congenital heart disease with the stent and bioprosthesis in the pulmonary position, and there's this kind of re-entry going around the ventriculotomy on the lateral RV wall, which failed previous ablation procedures, and just only combination of RF and pulse field. And I believe that's what gives you the biggest lesion. If you combine RF pulse field on the same site, was able to really ablate through this 1 centimeter myocardium and terminate the VT, and the patient is more than 1 year without their recurrences. I consider pulse field a very good source for epicardium because you don't endanger phrenic nerve, you don't endanger collateral structures like stomach or esophagus or other organs. And it can be used, you can nicely, this is where the late potentials find in the epicardial space, which we eliminated. And still, I believe it's important to map epicardially because the endo was normal. The endo was normal, it was just here. These late potentials, like ablating these late potentials, the endo was untouched. So I believe that's very important. There's one caveat when you're using these larger footprint catheters that they were never made for the epicardial space. So if you move it in the dry epicardium, you may actually, it works like a sandpaper a bit. So what we do now, we inject about 100 milliliters of cc's into the pericardial space of saline. And then you can freely move and you just do the mapping, and before the ablation you may aspirate everything back. So this is just was a learning point, how to make the procedure easier. This is the Sphere 9 in the dry pericardium. It's a very limited space there. If you just infuse a little bit of saline, then you can move it very freely. There is also, obviously, if you ablate in the pericardial space, you have a risk of phrenic, not phrenic nerve palsy, but spasms. So this was the non-ischemic cardiomyopathy. We started somewhere ablating here. This was the spasm. No ECG changes usually for this one. If you just give nitrates, there is a resolution. There are data that pulse field probably gives you more acute changes, acute narrowing spasms after pulse field than RF. But in the chronic histological changes, which is probably more important, the RF is worse than pulse field. Obviously, more to follow on that. And I believe also it depends on the size of the catheter, whether the catheter is a small footprint like a focal catheter, or it's a large pulse, a large area ablating catheter that also gives a difference. We also learned that there, because of the size of the sphere, it's not possible to enter every single recessus that we were used to do with the focal catheter. So this was a patient that had a Affera ablation in an RV, was non-ischemic cardiomyopathy. We ablated here. The patient had a recurrence of very slow VT and was just one single burn under this hinge of the tricuspid valve in the inferior wall. In other words, there are some small spaces in the ventricle which are maybe limited to get to if you have a larger footprint catheter. If you have a focal 4 millimeter, you can easier get into some of the, for example, base of the papillary or in between the trabeculae, closer to the surface. Obviously, if you have a Posemai scar which is smooth, that's not an issue. But there are other kind of things that we encountered, and that's entrapment of this larger footprint catheter in the mitral tricuspid apparatus. Generally, if you have a 4 millimeter tip catheter and you go around the papillaries, you may just get entangled in the tendini, but then you withdraw it. If you have a sphere at the end, you may be limited. So this was a complex case of congenital heart disease, VT ablation, was transposition of great arteries. That's not important, but the important thing is we were retrogradely and somehow got stuck into this tendini, and we couldn't really, it's like a spring. You try to get it out, and if you push really hard, you probably rupture the tendini. So because we were retrograde, we couldn't slide the sheet over, so we did the transeptal puncture. We used this grasping device and get the sphere and pull it back into the this was Farah drive from Farah Pulse, so a large sheet, and we get it back. So we cut the arterial here, and we pull back the catheter out of the. So you don't have to do this. It's better to prevent. Better not to go around the papillaries like this, or just use transeptal, and if you get kind of entangled, just slide the sheet over and be less use. Only you can still use retrograde, but just for some limited cases that you feel that it's important. And lastly, it doesn't stop with this focal catheter or the larger Sphere 9. There are new technologies. Vivek will have a talk about this. We also tested this in some patients, and this is a catheter. It's a focal catheter, but gives you much more energy into the tissue, and it's able to produce from endocardial sites epicardial lesions. So this is something that will probably be available. So this is like the movie Good, Bad, and Ugly about the VT ablation for and pulse field. So the other good things are that there are no more steam pops even if you put a lot of energy, and it's probably better penetration in the scarred myocardium. And you are in a specific location like coronary sinus, tiny spaces. You're not limited by impedance and temperature rise. There are some bad things that may happen, the spasm, but I still consider this lesser evil to have a spasm like the thrombotic occlusion with the RF. I didn't talk about the conduction system. We try to avoid it. We don't know, but probably it's not a good source for really close to the AV node. And the other problem that I didn't talk is that if you do a lot of lesions, the reversible zone may be large, and the non-inducibility at the end may not mean that you're done with all the arrhythmias, because they will just somehow, the lesion will shrink. And there are some other potential problems, like if you do too many lesions, there's real risk of hemodynamic deterioration, acute heart failure. There are some technical issues which obviously will be solved, like this combination of Centauri Smart Touch and the leakage from the proximal electrodes. And if these large footprint catheters are available, also the entrapment and the mitral tricuspid apparatus, I strongly recommend transeptal approach, because then you can slide the sheet and collapse the sphere back into the sheet. Thank you for your attention.
So, thank you, Peter. We will have global discussion at the end, half an hour.
We'll leave, so...
Oh, all right, so, I'm sorry. So, do you have any burning question? Because Peter had to leave to live case, to ICAM.
Do you have any patient with more arrhythmias after the ablation than before?
You mean, yeah, there would be... increase? No, we haven't seen that. We haven't seen any inducibility, an induction of the arrhythmias during the pulse field. The pulse itself does capture during the pulses. It does capture, so you can see on the pressure curve there is a capture, but usually it doesn't induce the VT. It may stop VT if you do it during the ongoing VT. So the termination during pulse field ablation is maybe not that specific like in an RF. But to see some inflammation and some rebound or some blanking period, I don't really remember to see. We've done about 70 patients with Sphere 9 VT ablation, and that was not a real issue. No. We don't see AF coming back after Farapulse cases either, so there's no real reason to think that that might be more different to that. Okay.
Another question? No? So thank you again. And I would like to invite Tom de Potter, but I have just seen that he had left the room. I don't know if he's coming. So if this is the case, Ivo Roca may give his lecture on, we will switch the lectures on how to optimally assess the arrhythmogenic substrate in VT ablation. He's just coming. Sorry for that.
Very sorry.
So now we are in our standard harmonogram, ultra-low cryo. Tom, please.
Yes, thank you very much. I'm terribly sorry. I found one issue on a slide, but I'll explain it to you. So thank you very much for the kind invitation. It's, as always, a great pleasure to be at this meeting. And what I would like to do in the next 15 minutes is go over the experience we have using ultra-low temperature cryoablation for VT ablation. As we just heard from Peter, there are obviously limits to existing technology in VT ablation. There is a limit to the lesion depth we can achieve, especially in special settings, for example, beyond the scar. VT ablation, as we also saw, RF VT ablation is certainly not free of complications. And this means there is a long-standing ongoing search for adjunctives to RF ablation, such as changing the irrigation fluid to achieve better current, for example, such as delivering the RF ablation through a needle, or alternative energy sources. We just saw pulsed field ablation. There is external radiation therapy, of course, and what I would like to go over today is the use of cryoablation. Cryoablation in VT ablation is certainly not new. There are decades of experience in surgery using very powerful cryoablation tools. Most of these tools, due to the coolant that is used, are not readily available in percutaneous settings because you cannot use liquid nitrogen, for example, at room pressure in a percutaneous catheter. The cryocoolants that are available in percutaneous catheters have been used, and some advantages or potential advantages have been reported. For example, there seems to be a far lesser risk to damage to the coronary arteries. And obviously, there are unique properties of cryoablation that may be attractive in very special settings, such as the fact that when you do a cryoablation, the catheter sticks to the tissue. It will not move again, which may be a very useful property if you are doing papillary muscle ablation. So this has been published, and what is typically reported on cryoablation in the setting of percutaneous catheters is that yes, it is far more stable, and there seems to be far lower risk of coronary artery issue at the expense of the fact that the cryocoolants we have do not provide very deep lesion formation, and the catheter maneuverability tends to be limited. Ultra-low temperature cryoablation is a technological development which allows the use of liquid nitrogen by compressing the nitrogen to extreme pressures. I'm not going to go into detail on the physics of it, but the end result is you can now use liquid nitrogen and its associated boiling point, of course, of almost minus 190 degrees Celsius in the tissue, in the beating heart. And this leads to an intracellular temperature that is achievable now that goes well below minus 30, minus 40, which is the temperature we want to achieve if we want to create reversible lesions. So this is what the catheter looks like. This is how the catheter appears in vitro. This is the catheter tip. You can see a 15 millimeter ablation element. There is a console. The catheter is deflectable. It's a 9th French catheter, and it has electrodes which can be useful to integrate the catheter in an electroanatomical mapping system using impedance-based mapping, or which can be useful, of course, to pace or to assess electrograms. Here you see typical ice ball formation in body temperature water, and you can see below on preclinical and bench testing the type of lesion depth that is typically reported. This is how the catheter looks like if you put it in an existing 3D mapping system. So here again, we are using impedance-based mapping. We are not using a sensor on the catheter. You can see intracardiac ultrasound, which is typically used with this technology nowadays due to the lack of integration. And you can see the typical effect of an ablation. And I don't know if this pointer is going to allow me to go into the movie. I don't think so. What you see here is an ongoing freeze, at which time, of course, the electrodes are covered in ice and noise appears on the electrodes. But at the end of the freeze, you have the pre-freeze snapshot here for reference. At the end of the freeze, you will see elimination of the near-field electrogram. You will see that only a far-field residual potential remains. I don't suppose there is a mouse here, because I do have time points in the video to click to.
Maybe take it off the laser pointer.
Ah, yes, that will help. Fantastic.
Sorry.
Okay, so what I want to show you very simply and briefly is this. There we go. This requires some hand-eye coordination, but there we go. So this is the end of the freeze, and there you typically see the noise disappears, of course, and this is a typical result of a single freeze, only far field remaining. As mentioned, technology is quite capable of making deep lesions, both in healthy and in scar tissue. Here you see a comparison of scar formation in healthy in green and in scar tissue here, and you can see lesion depths on average exceeding 10 millimeters, both in healthy and in scar tissue. Interestingly, in this particular study, also the combination of ultra-low temperature cryo and pulsed field ablation was studied, but I'm not going to go into detail on that in this particular talk. And here's a clinical example of what I just discussed of this lesion formation in scar tissue. This is a single case report that was published by the group of Boris Dinov, which he was kind enough to share, but he told me they have a case series of 6 patients in preparation where you can see a patient with pre-existing scar due to sarcoidosis in the septum, and you can see clearly that after ultra-low temperature cryoablation there is substantial extension of the scar in the septum, which obviously in this particular patient was the therapeutic goal of the procedure. And here you see another example of the clinical manifestation of lesion formation of the catheter. This is a live case done by Roland Tilts, where you can see that the cryoablation catheter is endocardially, and you can see here in the freeze, noise again appears on the electrodes of the cryo catheter, but you can see that also Roland is doing simultaneous epicardial mapping, and you can see that this epicardial ventricular electrogram is eliminated during the freeze, again potentially illustrating complete transmural lesion formation. We also studied this technology in the setting of synthetic material, synthetic patches, where we did a bench study to assess the potential and the potential improved efficacy of this technology over RF ablation if, for example, a surgical patch is present. And we reported indeed that with both RF ablation and ultra-low temperature cryoablation, there is an attenuation of efficacy. Both technologies lose efficacy to some degree if a synthetic patch is present, but we reported that this reduction is much more pronounced for RF ablation as compared to ultra-low temperature cryoablation, where you can see after the typical two cycles, we do a freeze cycle, as you do with existing cryo technology. You see we lose about 20% of lesion depth as compared to over 50% for RF. Technology was studied in a clinical trial called the CryoCure VT trial, where we studied 64 patients in 9 centers. You can see participating centers here. Prague recruited patients as well in this study. And these are procedural characteristics of our patient cohort. About half of patients done under general anesthesia. Most of the patients received the substrate mapping-based strategy for their VT ablation, and you can see again, as already mentioned, that intracardiac ultrasound was used in the majority of cases to supplement the limited mapping capabilities the catheter has today. This is the distribution of freeze durations. The vast majority of patients received a 2-minute freeze, 120-second freeze, as you can see in the middle, and of those, the vast majority received the typical freeze-thaw freeze cycle. Overall, in the patient population, on average, 9 lesions were delivered per patient, and per lesion, the average freeze duration was 3.8 minutes. You can see that in terms of safety, we believe we reported an excellent outcome. We had 0% of our protocol-defined major adverse events, and the adverse events that were reported in the study, you can see here, did not lead to any particular clinical consequences at follow-up. In terms of acute efficacy, which was the first endpoint of the study, you can see that in our patient cohort of 64 patients, 10 patients are not assessed because 3 of them were not inducible at the beginning of the procedure and 7 were not attempted to re-induce due to potential instability of the patient at the decision of the operator, leaving us with 54 patients assessed. Out of those 54, 94%, 51 out of 54, had elimination of inducibility of their clinical VT, and 85%, 46 out of the 54, had elimination of inducibility of any VT. And this is a slide I want to change, but it's no big deal. So our recurrence analysis, this is again the primary clinical efficacy analysis of the CryoCure VT study, is at 6 months. And at 6 months, we reported an 81% freedom of ICD shocks in our population and a 60% freedom of any VT. And we have now, Atul Verma presented at HRS, we have now completed follow-up up to 1 year, and you can see that there is no substantial further decrease in these numbers. You can see from here to here that we have a decrease to 72.8% overall efficacy in terms of freedom from ICD shock. And this is the same data shown more visually in a waterfall plot as a reduction in the VT burden. Again, on the left here, the primary analysis of the CryoCure VT study, 6 months post-ablation. We reported this data in Europace last year, and you can see that the vast majority of patients, of course, had a very, very substantial reduction in their VT burden, with a small subset of patients either remaining equal or a few patients seeing an increase in VT burden. And we have now also extended this to 1 year follow-up, of course. And you can see, first of all, that overall there is no major change in VT burden. It remains unchanged compared to the 6 months analysis. And you can also see that in those patients with early VT recurrence, there is a significant reduction in their trend to late recurrence. In gray, you can see patients that are censored, most of them because they were retreated. A single patient died at day 183, 6 months after the procedure, from heart failure. And this is the same data, just shown in a different way, saying that over half of our patients, if they experience recurrence without an ICD shock and undergo fewer than 3 ATP events, which is an outcome that certainly stands next to existing or published data on VT ablation. This is data for perspective only. Of course, there is massive difference in setup between these studies, in definition of the endpoint, and of course none of these studies are randomized. Finally, an outcome assessment on hospitalizations and re-interventions. I already showed you the patients that received re-intervention. On the left, you can see that virtually none of our patients underwent VT-related re-hospitalization at 1 year follow-up. And you can see that there is a single congestive heart failure death at 6 months post-procedure, meaning that our rate of VT-related and cardiovascular hospitalization is low in our patient cohort. What is still ongoing is a similar analysis in a US pivotal IDE study called the Fulcrum VT study, which is ongoing and recruited, which has already reported its acute efficacy data at last year's HRS. Results very similar to CryoCure VT, despite the fact that in Fulcrum VT there is a much stronger weight of non-ischemic cardiomyopathy patients, which are typically considered harder to treat with focal catheters. And in terms of development, a catheter has been developed, has not been used clinically yet, but has been used preclinically, which allows use of commercially available 8.5 French sheets, which is more maneuverable and which importantly achieves its target temperature much faster at deeper nadir temperatures, meaning we can hopefully look forward to a bit faster lesion formation still. In conclusion, our data, I believe, supports that endocardial ultra-low temperature cryoablation is safe and effective in patients with both ischemic and non-ischemic cardiomyopathy, and the utility of this technology in PVC ablation, although not specifically studied in our clinical study, is being established via clinical experience. There is more data on the way, both real-world registry data as well as trial data, the Fulcrum VT study most importantly, as I just showed you, and there is technological evolution on the way, targeting integration into routine clinical workflow using routine clinical tools and allowing faster and deeper lesion formations. And with that, not only would I like to thank our staff, I would also like to thank, I don't know if he's in the audience, Professor Kautzner. Some of the work I showed you was part of the PhD thesis I performed at Leuven University, and Professor Kautzner was one of the external jury members for that. So thank you very much.
Perfect lecture, thank you very much. And because of Tom will stay with us up to the end of the session, we will discuss at the end. And Fermin, mic is yours.
Thank you so much. It's not yours. I'll introduce Ivo Roca from Barcelona, who is going to talk to us about the best assessment for optimal assessment for arrhythmogenic substrate mapping. Welcome, Ivo.
Okay, thank you. Hello, everyone. It's my pleasure to be here. So thanks, Peter, Joseph, and all the team on PRAGUE for this kind invitation. And after these two amazing lectures about ablation, let's go back to mapping again, because I think there is still a role for mapping. And we need to map before destroying all the tissue with these very nice PFA tools. So let's map before. So these are my disclosures. And, this is not the last one presentation. Okay, well, anyway. So all of us know what is an ischemic BT. It's a scar-related BT, and you can see here the scar in white, and there are two small channels that are crossing the scar, and that actually these channels are the one that if you go for optimal mapping, you can see that BT is using these channels. So BT is always a matter of a scar and slow conduction. So we are going to talk the next minutes, and I'm sorry because this is not the last presentation, but I will try to figure about scar and slow conduction. Because all of us know where to ablate if I give you this kind of maps. So it seems like a re-entrant map. So in your left you have like a BT map, and your right you have the 80 grid catheter working inside the MRI with some channels. In red is core scar, in yellow is border zone, and in blue is healthy tissue. And if I give you this kind of maps, all of us are going to be very, very easy to know where to ablate. And as you can see in the tracings, this is not a BT map. This is an S3 map. So this is an island map created by putting extra stimuli in the ventricle. So if you are going to use functional mapping, and that's what we are going to talk about, we always are going to have this kind of map that mimics a BT. And that's the beauty of doing functional mapping, because it's easy to you to understand where to ablate, because it's almost having a BT map without needing the BT in your patient. So we're talking about imaging and functional mapping. Just a brief idea about what I think imaging is important, because I like the presentations of Schiff and Fermin this morning that BT is a 3D substrate. So we are dealing with electroanatomical mapping systems. And with electroanatomical mapping systems, you can map the endo or the epi. And this is a very elegant study from Rod Tang's group. And they show that even in patients, you can map the full circuit of the BT in the endo or in the epi. Even in those patients, there is always part of the circuit that is midmural. And you don't know which part of the circuit is midmural with your electroanatomical mapping system. On top of that, every patient is different. And that way, again, anatomy is critical. So understanding your substrate, understanding your enemy, it's critical before ablation. And this is a very elegant study from Katja Zeppenfeld in Leiden. And they showed that the scar can be endocardium, can be, sorry, because it's not easy to move, supraepicardial, midwall, or transmural. But if you are going to use just a high-density mapping system, you can map the endo or the epi, but you cannot map the midmural. So with imaging, you have a tool that gives you a 3D idea about where is your substrate. I will go fast, because again, this is not the last presentation. So with using imaging like late gadolinium MRI, conventional MRI, you will have an idea about where is the distribution of the scar. In red is core scar, yellow is border zone, and blue is healthy tissue. And then you can have an idea about not only where is the scar, but how depth is the scar. You can see in this patient an anterior infarction, and you can see that you can understand the scar from the endo side, 10%, so close to your blood pool, to the epi, so 80%. So it's not only where is the scar and how extensive is the scar, but how transmural is the scar. And then you can say, okay, there is a part of the scar that is not completely dead. So you have a channel that is crossing the core scar and connecting to areas of healthy tissue. And that's what imaging can tell you even before puncturing the groin. And on top of that, okay, but how depth is this channel? Because if I see this, I could say, okay, let's go to the epicardium because it's in this 60, 70%, 80% layer, so outside. But if you go to the wall thickness map of the same imaging, same patient, you can understand that the entry and the exit of this channel is very thin, less than 5 millimeters. That's why you don't need to go to the epi in this patient. Actually, we didn't go to the epi and we mapped just from the endo, and you can clearly see that you can see the diastolic component of the BT from the endon side, despite it's an epicardial channel. And on top of that, you can merge imaging, and you can ablate based on that. Look at this case. This is a BT map. You see the age grid doing the BT map, the age grid inside the CT scan with a nice channel here of preserved tissue. And you can see that the exit of the BT is exactly at the exit of this channel. And so you can ablate also based on both mapping and both imaging. Why do you have to choose between imaging and mapping? Just take advantage of structure and function. So I will skip this for a matter of time, but more than 90% of desiccation zones are inside MRI channels. So why mapping if imaging is so great? Because it's not only about substrate, but about functional. Because it's true that 90% of desiccation zones are inside MRI channels, but it's not the other way around. It doesn't mean that 90% of your MRI channels have slow conduction properties. Otherwise, it would be very easy. Just put a ferrocatheter there in the scar and ablate it, okay? So we look at that, and we found out that 1/3 of the MRI channels had no slow conduction properties, so you don't need to ablate those channels. Those channels are just structural. So what I think it's nice to map functional against voltage, and I will skip this. So look at this voltage map. This is less than 0.5 millivolts, okay? So where to ablate based on the voltage map? Obviously, if you ablate everything, you will get rid of the BT. But that probably is not the most efficient way, okay? So then you need to understand where is the critical part of your low voltage area to ablate. You can do it inducing BT, but that's sometimes difficult in center patients, or you can analyze what is the propagation of your substrate. You can do an activation map of your substrate. Because sometimes the latest part of the circuit, like in this purple area, it's not the critical one. Because if you arrive late at home, the problem, it's not at home, it's before, okay? So obviously if you arrive late at home, you will have a problem, but you have to fix it before arrive at home, okay? So it's not killing the late potentials, the solution. It's killing the slow conduction that makes these late potentials to be late. And that's why I think functional mapping, it's nice to understand why they are late. Why functional mapping? Look at this VT. If you see how this VT starts, let's analyze the tracing, because remember, we are not painters, we are electrophysiologists, so we have to look the EGMs, okay? Look at this S3 protocol. So this is the S1. There is a clear delay between the far field and the near field, this late potential. We put an S2, so a shorter coupling interval. There is an increase of delay from the far field to the near field. Not only that, but also the pattern of activation is changing a little. But look when we put the S3. When we put the S3, there is a change of the delay, but also there is a unidirectional block in this part of the splines, and then you produce a reentry. So if you see this kind of behavior by using functional mapping, you don't need any map. This is a critical part of the BT. You don't need even any color, okay? Actually, functional mapping, deep mapping, was invented by people from Canada, Andrew Port and Nanta Kumar at that time. But what they did is, okay, when I see late potential, then I put an S2 stim. So they needed a priori condition. And what they proved is, okay, you don't need to ablate the full late potentials. You just have to ablate those that has decremental properties. But still you have 25% of recurrence in less than 1 year, okay? Then the group of Katja Zeppenfeld-Leiden did more or less the same. When they saw low voltage area, they put extra stimuli. And they said, okay, if you put extra stimuli and the late potential doesn't have decremental properties, do not ablate. Look the difference between this non-deep potential and these deep potentials we have decremental properties. But again, two things. It was manual annotation, and you need an a priori condition, low voltage area. At the same time, Antonio Ruiz from Barcelona said, okay, if you suspect something inside your far field, put extra stimuli. But it's not easy for all of us to suspect things. That's where we decide, okay, let's see if we can do a full functional substrate map. Because at the same time, we were evaluating how the slow conduction areas were changing during ablation. Look at this map. We ablate this area of desaturation zone, and then remap, and another area of desaturation zone appears. That's very annoying at 2 p.m., okay? We are hungry, so we don't want surprises, okay? Then we ablate, and everything was clean. But this is not exceptional. If we don't use functional mapping, if we just stay in sinus or S1, 20% of your cases will have new desaturation zones after ablation. So the question is, could we improve our first substrate map? So why not mapping functionally the full ventricle, not only low voltage, not only when we suspect things, not only when we see late potentials? Look at this S3 map. This is an S3 map, and look in the putting extra stimuli, how many late potentials you see that you are missing if you don't use this S3 functional map. If you see the propagation of this S3 map, it looks like a VT. It's very easy to tell your fellow, okay, where do you have to ablate? It's easy. This is the slowest conduction area during the S3 map because you are mimicking re-entry. Actually, if you see the tracing of this patient, you can see why these late potentials are late. Because they are delayed here. So probably if you ablate here, all of these late potentials will disappear. So you map more, but you do not ablate more, okay? Because you understand how it works. So this is the S3 study that we did. So we tried to do this S3 map prospectively in more than 40 patients. How we do it? We do a S1 600 milliseconds 6-bit train to stabilize the refractory period. Then we do an S2. It means that we check the refractory period and we increase the coupling interval by 30 milliseconds for the S2 and by 50 milliseconds for S3. Why 30 and 50 and not 20 and 20? That was the original description of DIP. Because if you do S3 using 20 and 20, you induce a lot. And we want to map. We don't want to induce, okay? Look at this example. This is an S1 map, okay? So it's nice late potentials there. Nice propagation map. Then we induce BT. BT was nice. Diastolic components. We stopped the BT by ablation. Everyone was big applause, very happy. But if you look at the MRI of this patient, what about this channel? This is a very long channel. And we have understood that long channels must have slow conduction. We have checked some properties of the channels, and we have understood that channels over 10 millimeters or 25 millimeters have a slow conduction. So if you have this kind of patient with this channel that has no late potentials, if you see the S3 map of the exactly same patient, look at this area of late potentials here that you were missing using just S1 or sinus. So by using S3, you see much more things. I'm sorry, you have to ablate a little more. But I think that's benefit for the patient. So you increase the area of desaturation zones. This is S1, S2, and S3. You increase the area of late potentials. you increase the sensitivity for detect BT isthmuses, and I think, and this is not updated, after 3 years, you have less than 90% of BT recurrence. Because at the end, as I showed you before, this is the case that I showed you at the beginning. Sorry, it's not working, no problem. So I will end up with a clinical case. This is an S3 map, epicardial map of an ARBC. Look very nicely at deceleration zones. This is the S3 endocardial map. Why these late potentials are isolated here? Because probably are coming from the epi, going up, and going to the endo. So you understand the activation because you are stressing the tissue. And look, these late potentials that are not seen by using S2. This is the S2 and this is S3. And one could say, okay, but then we are losing S1 and S2 map. No, you can do a turbo map of S1 and S2 because you have already go there with the catheter. You don't need to spend time to do another map. You just tell the technician, okay, show me the S2 and the S1 map. This is the S2. Now here you have the S3 here. Sorry. And this is the S2. So you are losing, if you are not putting the S3, you are losing this area of late potentials. And you will see here that this area is critical because in S1 you don't see this area, in S2 you don't see this area, and in S3 you see this nicely late activation from here to up of this area. This area is critical. It means that this area has functional delay, and functional delay is what we need for re-entry. And that's why we put the grid catheter there, and only at that step we induce, because we know that probably this is the most critical area. And you have seen that now, you will see, we induce, and even without any color, with the catheter at this area that was unmasked with S3, you see the full diastolic component during BT. So you can create activation mapping of the BTs within the first 2 or 3 beats. So we ablated this area, but this is not enough. Non-inducibility to us is not enough. We have to remap. So we did again the S3 remap, and this is the final result. So this is epicardial S3 map with a lot of deceleration zones, a lot of slow conduction, and after ablation, this is a normal propagation of the epicardium. And only at that time we induce, because we want first to have no slow conduction and then non-inducibility. So I would conclude that I think voltage mapping, you have seen any voltage map here. We don't use voltage map because I think voltage map it's just a rough idea about where is the scar. Imaging is useful to understand the full 3-dimensional idea about the substrate. Slow conduction, deceleration zones, to me, are more specific than late potentials because they show you where is the problem. And functional mapping using S3, I think it's nicer to identify the critical areas, but it's true that we need to prove that this is better than other strategies. So thank you very much.
Thank you, Ivo. That's very nice. I think we will ask you some questions because you have to go to the hospital. I will let the audience first if there's any questions for Ivo. When you start the map, how do you then focus in that area? Like, if you start doing it, seems like you have a full map of the ventricle. Do you put the grid in different areas, and then you finally find the area that has the late potential, so you use that area suspected from the initial map?
Yeah.
You know what I mean?
That's a key question. We don't have initial map. So our initial map is the S3. So what we do is, if we have imaging, as we will try to do together with Peter today, we focus the area in the imaging. But if you don't have imaging, we do a full substrate S3. So we don't have voltage map, we don't have S1 map, and then decide to do an S3, because then probably it's not very efficient. So we do always the S3 as a live map, and then retrospectively we look for the S1 and S2 to see differences. But our main map is S3 from the very beginning. It's not low voltage area and then S3.
But that would be if you don't have imaging. If you have, so then the real, I guess, practicality of the protocol is suspect the area based on imaging and then focus in that area?
If you have imaging, yes, but the study that we published, we did it on purpose without imaging to prove that you can do it without imaging, and the procedural time was 190 minutes or so it's okay. So from the very beginning, S3 in the full ventricle. Obviously, if you see that there are nice signals, you will focus more, and if you see that it's healthy, you will spend less time. But we do a full ventricle map if we don't have imaging.
So you just position in different areas to
Yeah.
S3 position.
Collect points, move.
You change the areas of S3 transition zone to another place. Do you still induce VT from that other place, like a
No.
different exit?
No. So we try to avoid VT as much as we can. My feeling is that in ischemic patients, VT induction, doesn't give you a big added value because the substrate is easy to understand when you have this S3. It's different in non-ischemic. So we only induce once when we have all the map done to see at least what is the most inducible VT, to at least start with that area. But then we ablate the rest of the areas, and only when the map is clean, we reinduce again. Because inducibility sometimes is a matter of statistics.
Area?
Sorry?
Would you target the second area?
Yeah, all the areas. We target all the areas. Yeah?
What about extrasystoles when you move mapping catheter?
I don't think they can hear me. Why not?
Non-sustained ventricular tachycardias. Do you wait in that place or omit some places?
I try to do not omit any place. I wait. With AG-grid, I would say that the number of PVCs are very low. With Pentagrade, because it's more free, the splines, then you have more irritation. But with AG-grid, the amount of irritation, it's very low, with the exception sometimes of papillary masses. But the rest, especially in a big heart, I think with AG-grid you have no problems of PVCs.
And do you discontinue antiarrhythmic drugs before the procedure?
Even in an ischemic patient, no. In a non-ischemic patient that we don't have any clue on imaging, then yes. If we have imaging with clear substrate, then we don't stop. Because on the other hand, you should stop for 1 month, 2 months at least.
Post-procedure, do you do inductions? What is your approach? What is the endpoint for the case?
Yeah, the main endpoint, it's both non-inducibility and, more important, clean S3 map. Because there is a very nice study from Phil Stevenson that proves that after mapping, before ablation, the rate of inducibility decreased by 30%. So then, non-inducibility alone, to me, it's not enough. With the exception of very fragile patients that you want to just take the money and run, but usually we go for everything.
Thank you. Thank you very much. Next talk, is Vivek here or online? Online, okay. VT ablation with field technology, can we go transmural? And I think we have Vivek in one of the hospitals, so he's gonna join us remotely. Welcome, Vivek.
Hi, can you hear me, Furman and Dan?
Yeah, we can hear you, we can see you.
Okay, fantastic. Okay, hopefully my slides will come up in a second. I'm sorry, I can't be there physically. I've been watching many of the sessions actually, or many of the talks, but we're going to be starting cases very soon. Anyway, so my charge is to discuss VT ablation with field technology, field medical technology. Can we go transmural? And these are my own disclosures as relevant to the presentation, field medical, and this is a device, a catheter that does not have regulatory approval anywhere in the world. So these are, what I'm going to present today are basically data that we recently presented both as a poster and as a late-breaking trial at HRS a couple weeks ago. And this VCAS trial is the first in-human study of this technology in scar-related VT conducted at 2 centers, at Homolka Hospital and at ICAM. The catheter itself consists of the ablation catheter and the generator. The catheter delivers monopolar pulse field energy, at least for the purposes of this VT ablation study. And these are high voltage pulses. there's a multimodal trigger to allow triggering and delivering of these 200, approximately and less than 200 millisecond pulses to be synchronized to the QRS. And each lesion consists of 5 applications over successive heartbeats. The catheter is called the field force catheter. It's a 8.5 French bidirectional irrigated catheter. It does have force sensing. It's magnetically enabled for localization, but as you'll see, we're not currently using that because currently the catheter is not yet integrated with any mapping system. So the integration, such as it is right now, is based on electrical impedance. There's also, the catheter, if we look at some of the preclinical data, what you see, and I'll just have you focus here on the chronic data, 1 to 5 day survival. If we look at the depth, with this one lesion, so 5 applications over successive heartbeats, you can get depths of 12.5 millimeters, and that pretty much is transmural, is what we've seen. And now, we've seen transmural lesions in many preclinical studies, and the question was, does this actually translate in patients? Because we've seen a lot of preclinical studies show very big lesions that don't actually translate to transmurality in patients. There's also a deflectable sheath that comes with the system. In terms of mapping, as I said, the catheter is not currently integrated with any system. We used it with the CARDO system in this particular study, where we would map with the multipolar catheter and then use the electrical impedance localization to position the catheter. What I'm going to show you is the general strategy. Pericardial access using the Pericross device, and we'll get into that soon. Then typically, if we could get epicardial access, meaning the patient did not have cardiac surgery, we would do epicardial mapping, then endocardial mapping, and then target ablation, typically starting endocardial. And then we would always do both endocardial and epicardial remapping. This is, again, a first-in-human study. It was prospective. 2 centers included adults who met class 2A or B indications for VT ablation and had at least 1 documented VT on an ICD. The primary endpoint of this first-in-human study is really focused around safety. But of course, we have questions about VT-VF inducibility, VT-VF burden, mapping results, and of course, procedural efficiency. There are a total of 20 patients. You can see the mean ejection fraction was 35%. The majority of these patients had a prior myocardial infarction. The time to infarct was about 6.3 years. About a third of the patients had a prior VT ablation, and a third had a history of VT storm. 21 patients were enrolled, of which 1 there was a screen failure. So 20 patients ultimately had the catheter inserted during a procedure. 1 patient was early exit, the procedure was aborted. The 19 patients that completed the index procedure, we have follow-up ICD interrogations on 18. Actually, now I think we have all 19. Since it's not integrated, how do we do the procedure? Well, how do you annotate the ablation lesions? Well, what we do, as I said, is we create a relatively dense map with the multipolar catheter. Then we could see the tip of the ablation catheter. And this is what you're seeing here, the 2 electrodes at the tip of the catheter. So these are localized by electrical impedance mapping. Then we would pick one of these points and make that an ablation point. Then you have to turn off the magnet because we don't want to hurt the mapping system when we deliver the energy. Then we ablate. And then we turn the magnet back on, and we verify that our catheter is still in the same position. So that's the protocol we used. It's a little cumbersome, but anyway, that's what we did. Most patients, we use this strategy. So we would do a baseline endocardial map and epicardial map. And if you look at this patient, for example, there's a very large endocardial low voltage, smaller epicardial. Of course, we're also looking at the specific potentials. This patient had a number of different VTs induced, and looking at late potentials or function mapping, each patient had a different strategy. Here, for example, we would deliver these lesions. And if you look here, this was the baseline epicardial map. This is the post-endoablation epicardial map. So these lesions actually translated to full thickness lesion, low voltage. Let me just take you through one case example. This is a patient. First, we mapped epicardially. There was relatively low voltage. You're looking at here at posterior basally. And then during induction, you can see we induced a VT here. And what we had the catheter in sort of this posterior basal position. I'm going to, interest of time, I may jump forward a little bit. What we're doing is a quick activation map. And you can see that the earliest activation was toward the base. Nothing was really that early, but it was right about in this location. So it was the earliest site, which was right around here, not terribly early, just at the beginning of the QRS, and you would see spread of activation. Recall again that there was relatively normal voltage here. So this we would argue is the epicardial exit. Then we did endocardial mapping. You can see the bipolar voltage mapping on the left, the unipolar on the right. So really suggested that there's a relatively small area of scar that may be more intramural. At this point, we couldn't induce VT again in this patient after endocardial mapping. So we did pace mapping, and not surprisingly, the best correlation, which you see here, was from this endocardial location. If we look at this just shows you the best endocardial map. So if we look at the actual location, so this is on the left is the epicardial activation map. On the right is the endocardial pace map, which is here. And this location, by the way, is here. So somewhere between here is probably the substrate. So what we did in this patient, we decided to plan for endoablation. This is transeptal, the ablation catheter. This is just the epicardial decapolar catheter just sitting in position. We also have ice, so we're looking at the location so we can see this. And of course, we had force sensing. And once we're in position, then we deliver the successive beats. And so you can see these red dots, which represent the various ablation lesions that we delivered. This is pre-ablation voltage map. This is post-ablation voltage map endocardially. Again, with endo lesions, this is the epicardial map. So this is baseline and epi. This is immediately after the endo lesions. We waited another 20 minutes and repeated the epi map. And again, you see the same sort of wedge-like low voltage, which again, recall, was not there at baseline. And again, here's the final lesion set here, and here's the endo and epi maps together. Okay, let's see. In one patient, we actually saw a larger epicardial scar, a diminutive endocardial scar. So we delivered a number of epicardial lesions, which you see here, and only a couple endocardial lesions. So this was sort of the opposite strategy. In most patients, we delivered more endocardial lesions. So a total of the skin-to-skin procedure time was 177 minutes, and you have to understand that involved a lot of mapping and stuff related to the protocol. The mapping duration, you can see, was about an hour. The transpired ablation time was 35 minutes, and you see the range. This is the time from the beginning of the first lesion to the end of the last lesion. Fluoroscopy time is shown. The amount of fluid delivered is not terribly much. In 13 patients, we did pre- and post-inducibility testing, and as you see, in most of these patients, the patients were no longer inducible. You can see that the type of mapping, we did endo and epi mapping, that was possible in 8 of the patients. And when we did endo-only ablation, which we did in 7 of those 8 patients, it eliminated all of the epicardial late potentials or abnormal potentials when they were present. If we look at RV pacing characteristics, this is pre-ablation. Post-ablation, there was an increase, but then this largely subsided by 3 months. There was one patient where it was elevated, but notice that the elevation occurred sometime between post-ablation and 3 months. So we're not exactly sure what the reason for that is, but probably not related to the ablation itself. If we look at freedom from recurrence, and here you see, again, over the 6-month follow-up, the survival probability. And if we look at burden, for example, this is VTVF burden pre and post, and here's a heat map that shows the number of events in these patients before versus after. Safety, and there's a number of safety parameters, as you can imagine. The primary safety endpoint was observed in 2 of the 20 patients, and one of them was an important device-related adverse event, or at least procedure-related for sure. This is a patient who had cardiogenic shock. But let me just caution about this patient. This is a 77-year-old patient that presented with arrhythmogenic storm, and he started decompensating prior to any PF lesions. I mean, really soon after general anesthesia, with an LA pressure that was quite elevated. We decided to start delivering PF anyway, and we stopped after 6 lesions because he continued to do poorly. We tried putting an impeller device. A cath showed significant coronary disease. The procedure was, of course, aborted, but in the hospitalization, he died of refractory cardiogenic shock. This was adjudicated by the CEC as causally related to the procedure, obviously, and possibly related to the therapy and device. There was a second patient who had a heart failure exacerbation who recovered and related to the procedure, unrelated to the device. So our observations so far with this technology is that PFA in the ventricle is fast, that based on the patients where we did endo-epi mapping, we saw transmurality with endo lesions alone, or conversely, in the one patient with epi lesions, we saw endotransmurality. This methodology of epi mapping after endo PFA may be a novel endpoint for future VT substrate modification studies. It's an approach that I like, and ultimately, of course, if we feel that we can really get transmurality, you probably stop doing epi mapping in certain patients. The early data suggests that this is effective in preventing VT. Of course, we need more patients and longer follow-up. There was an important safety event, as we just talked about. Of course, this population was sick, and really safety needs to be determined in a larger clinical trial. So where does this take us? If we think about VT ablation disease progression, I'd like to think about it in this way. We have, of course, patients who present with either primary or secondary prevention ICDs. Some of them eventually require an ICD therapy, get put on drugs, and eventually some patients received ICD therapy despite drugs. Now, we know from trials like VANISH that ablation is effective here. We also know from a number of other trials that ablation is effective even here. I guess probably the most recent data is in this middle population. We know from trials like PARTITA that there's a suggestion of a mortality benefit of ablation over drugs. Ablation versus not ablation. And then in SURVIVE VT, looking at ablation versus drugs, there was again an improvement with ablation compared to antiarrhythmic drugs for this primary endpoint of mortality, shocks, heart failure hospitalization, or treatment-related complications, which is mainly slow VT. We know it's the same from VANISH 2 that was recently published, again with this composite endpoint. But if you look at this, at least in the United States, VT ablation right now is largely performed in this population, despite these positive studies that we see here and here. And I think that devices like this may actually help. And in my mind, the future of VT ablation is really going to be separating the patient population, those that require VT ablation to those that will argue require substrate modification. What I mean by that is the patients who are, of course, admitted with ICD shocks, VT storm, et cetera, these are the kind of patients where you want to obviously do detailed mapping perhaps, or maybe not, but ultimately these are patients that will probably be inpatient patients where you want effective, efficient ablation. And I think that catheters like this that can get transmurality will allow us to treat these patients highly effectively. But I also think that when you're thinking about patients who you may target earlier, we should be thinking about a substrate modification approach where we can use these catheters hopefully reliably for these let's say, acute patients, perhaps same-day discharge, and render ICDs potentially as a truly backup strategy. So I think that obviously this conceptualization requires appropriately powered clinical trials where we conduct the trials to really think about efficiency and safety and try to make, at least in some patients, VT ablation like we did with PV isolation. Thank you very much. Oh, one last plug. The VT Symposium this year is in Philly in October, so please join us if you can. Thank you.
Thank you, Vivek. Exciting talk on technology as always. I'll ask anybody in the audience, do we have any questions for Vivek? Vivek, can you hear us?
Yes, please.
Yeah, I was wondering, what size is the tip of the catheter and what you feel about manipulation in this first version?
Yeah, so again, the catheter is an 8.5 French catheter. The tip is, it's very small. I don't actually know the exact number. They're two very small, closely spaced electrodes. One of them is about 1 millimeter. The other one is about 2 millimeters, separated by 1 millimeter. So the overall distance is about 4 millimeters. The electrical field goes between these two electrodes, and well, actually, I'm sorry. The electrical field for the VT protocol is monopolar. So it is being delivered from both of these two surface patches. Okay? So it's not just from the tip, it's from that whole two electrodes. In terms of maneuverability, it is a bidirectional catheter. The very first version that we had for the initial maybe 5-7 cases, it had real difficulty with deflection, I got to say. But since then, it's able to deflect bidirectionally quite well. And somewhat surprisingly, with the combination of the deflectable sheath and the catheter, we've been able to get to all the locations pretty easily. I was actually worried about that a little bit. But that has not been a problem in our experience. I do think, by the way, and let me just editorialize, I do think that our field needs better VT, transeptal VT sheets, because what we have right now, I just don't think they're very good, and I think that limits what we can do in many patients.
I agree with you on that. And that, I'm sorry if I missed it, but a lot of talk before from Tom and from Peter. What about spasm? Nothing that you could see of importance?
Yeah, we didn't, but again, I do want to mention, except for that one patient where we did epicardial ablation, all the other patients were really just focused on endocardial ablation. Now, having said that, look, there is certainly the possibility that since the field does appear to penetrate quite deep, we may see some epicardial spasm. I would not be stunned. We didn't shoot the coronaries in every patient. In some patients, particularly in the beginning, I was shooting the coronaries. Particularly, for example, like that one case that I showed where we're near the base, we shot the coronary, and we have not seen spasm. But look, there's no doubt that we'll see spasm if we get close enough. I mean, I have yet to see a pulse rate ablation technology that doesn't cause spasm. But, you know, as you know, said earlier by Peter Peichel, I tend to agree with him. While it's something we need to be careful about, I think there are ways to mitigate it. I mean, certainly with the other pulse field ablation technologies, we now have a lot of experience, and some of it now published actually from the Advantage 2 trial, that if you give nitroglycerin beforehand, you really eliminate the severe spasm. Now, how much do you need to give? What's the timing, particularly if you're using different pulse field ablation catheters? I think all this needs to be figured out. It's not as clear to me that you can just take the experience from one catheter and apply it to another catheter. So that still needs to be proven, I think.
Okay. Well, thank you so much for your...
Maybe I have one more question, Vivek.
I'm sorry.
Danny speaking. Do you have any remapping data by chance if any of these 20 patients underwent reprocedure because of recurrent arrhythmia? Just
Yeah,
to assess the
believe me.
durability of lesion.
I know. It's a great question. Look, I mean, your point is well taken. The transmurality that we're seeing appears, I mean, you're even just talking about durability, period. And I'm thinking also about the transmurality, durability of transmurality. And the real answer is no. There are 1 or 2 patients I'm hoping that we'll be able to bring back and restudy. I don't remember if those are patients that had epi-mapping the first time, but if they did, we would certainly want to try to do that again. Yeah, so the answer is no, we don't have any such data yet.
You also say recurrence, right?
Yes, no, we had a couple of
Not
patients
much.
with recurrence, but not many.
Yeah. You don't do NIPS after, huh? That would
I'm sorry?
It would be an interesting thing. Just, you know, we tend to do NIPS post-VT ablation. I guess that
Yeah.
this was not part of the protocol.
Yeah, I think that's something we've been talking about, having a dedicated protocol looking specifically at that. Because I agree with you. To me, that's a great endpoint.
Well, thank you so much. We appreciate
Thank
the
you.
time and the talk. Any questions? I think we're open to discussion, or I think we...
Yeah, we have 10 more minutes, and all these 10 minutes can be devoted to discussion of Tom's lecture because all other speakers are gone.
Yeah, I mean, I guess that we can ask them, even they're not here, we can...
So discussion to cryo-VT.
Any questions for Tom? He's been here all the time. waiting patiently.
You spoke about the potential utility in ablating on papillary muscle, and my thinking is when you ablate at the very tip of the papillary muscle, and when the tissue become very fragile due to freezing, is there any risk of breaking or a rupture?
First of all, especially for the papillary muscle, the imaging is extremely helpful. And if you do these cases with ice, yes, you can target the tip, and it's very elegant, and it's a scenario which with RF is extremely challenging, but you don't have to, of course. You can also choose to approach the papillary muscle from the base, from the side, from whatever you'd like. I'm not aware of any acute complication as you describe, like cooking or, I mean, there's obviously no steam pop, etc. What is clearly conceivable is you'll create damage, and in the grand scheme of things, there's not that many cryo-VT papillary muscle ablations that have been performed so far. I'm not aware of any massive rupture, for example, but yes, you'll create a substantial lesion, to be honest. You'll create necrosis, and it's conceivable at some point a papillary muscle will rupture, as we know can happen with RF, which may happen delayed after the case. I'm absolutely convinced that it's a possibility to take into account.
In your talk, you said there was one patient with a false aneurysm. What is that?
It's descriptive. So the patient that was treated was a patient with a particularly thin myocardium at the apex, was measured at 2 millimeters. And after the procedure, when the ultrasound imaging was performed again, it was seen that the geometry of the apex had changed, that it seemed that the catheter itself had created, if you will, a bulging of this apical part. It did not lead to any consequences. It was left untreated, did not require any treatment. But because of that observation, the protocol was changed to disallow ablation in regions of the myocardium where the muscle is less than 4 millimeters thick.
Yeah, yeah. That's good you clarified that, because when I saw that in your lecture, I thought if you're trying to say a pseudoaneurysm or like a contained perforation or something like that. So that's not the case. All right. Any questions for Tom? Okay. All right. I think we conclude. We finish a little early, coffee.